Hi, my name is Christina. This is a case study created by the Institute for Healthcare Improvement. This is the case study regarding an insulin overdose. A gentleman whom we'll call Mr. H is a 78-year-old man who was admitted to the cardiac ICU last night. During the admission process and exam, his abdomen was found to be extended and rigid. Ischemic bowel is suspected. Immediate surgical exploration is planned. Mr. H is prepped for surgery and seems stable, although his kidney function seems to be getting worse. The senior anesthesia resident on call is notified and prepares for surgery. The senior anesthesia resident on call has been working since 6:30 the morning before, and it is now 3 o'clock in the morning. The attending and the team prepare for surgery. Concerns are discussed, and the surgery begins. Mr. H was originally admitted to the cardiac ICU because of an active myocardial infarction. His health is complex, and there soon begins to be complications. The complications, including his kidney functioning poorly, cause his potassium to be high. Due to the concern the high potassium causes, some methods are used to decrease the level of potassium, including insulin. The attending has the senior anesthesia resident administer 10 units of insulin. The resident draws up 10 cc's of insulin and injects it into the IV line. Soon the resident realizes that instead of administering 10 units, he has actually administered 1,000 units. The attending is informed and proper care is given. Mr. H began as being very ill. The potential for complications was high. A serious medication error occurred. 1,000 units of insulin was administered instead of the 10 units that was supposed to be administered. The resident was unaware of insulin packaging and dilution necessity in the operating room. The attending assumed that the resident was familiar with the insulin used in the operating room, and the resident didn't confirm the insulin dosing with the attending. The issues in this case study can be resolved with better communication, as well as having surgically appropriate diluted medications available as needed when anticipated. Management and leadership can ensure that a maximum number of hours of work is enforced for all staff. The attending can ensure that the resident is familiar with the medications to be used in the operation room. The resident can confirm the dosage with the attending. Pharmacy can ensure that surgically appropriate dosages of medications to be used in the operating room are available. The proposed solution is to enforce a maximum number of hours work for all staff, to encourage open communication, and to create a system where pharmacy prepares the diluted solution for the operation room. The barriers for implementing the proposed solutions: the first would have to be resistance to change, which seems to be a barrier in most solutions. Another might be cost. It may be more costly to create a new system of insulin dilution prepared ahead of time. Another barrier for this proposed solution may be that instead of a systemic problem being seen by some, it may be that some see a smaller picture and instead blame the resident instead of the system for this medication error. Thanks for watching.